I think after ASH 22, I think we are a little bit closer to using MRD-guided treatment decisions, in myeloma. In particular, one of the things that there seems to be a theme with is de-escalation of therapy guided by MRD. We have several abstracts that are really trying to address this. Abstract 3237, which is the master trial, is an updated report looking at MRD-adapted DARA-KRD with transplant. And we know already from past reports and publications that 84 patients underwent treatment discontinuation completely on this study and are under MRD surveillance. What we get from this meeting, though, is that about 8% had some kind of MRD resurgence, meaning the disease returned at a microscopic level in about 8% of patients, and 13% have had some disease progression of those 84 patients, which leaves us with 79% or so of patients who are still off treatment at an average of about 2 years out since stopping therapy. Now, if we dive a little bit deeper into those numbers, though, we find out that 47%, though, are of the patients who had multiple high-risk cytogenetic abnormalities. It's only 47% of those people who are still in MRD surveillance without disease coming back. So to me, this takeaway from this abstract is that extended therapies with transplants, such as in the master trial, can definitely attain sustained MRD negativity and maintain it even after discontinuation. But for the high-risk patients, especially those with 2 or more cytogenetic abnormalities, we have to be very careful about whether we can ever discontinue treatment. These are not the patients who we probably want to be targeting for discontinuation. With that said, there were over 50% of those patients who still haven't progressed. So there's something underneath the surface that we still don't understand about who can stop. And I think that's the theme across all of these abstracts, is really figuring out what is the population who are the patients that can safely discontinue therapy. Along those lines, abstract 992 from the Sloan Kettering group shows that they're looking at maintenance therapy discontinuation as well. And they have a very stringent criteria. This is patients who have been on some form of maintenance and are having sustained MRD negativity for at least 3 years before they can undergo discontinuation. And then patients are going to be monitored on this study using a very high sensitivity flow cytometry that's somewhere between 1 in 100,000 and 1 in a million in terms of sensitivity, what we call 10 to the minus fifth, 10 to the minus sixth. And then they also undergo a PET CT every year. So right now, there are 23 patients that are being reported on, and 16 of whom have reached the 12-month mark. And the sustained MRD negativity at 12 months is 88%, so 14 out of 16, which is a very high number and very encouraging. And 94% of these patients have not had disease progression. So what that tells us is that at 1 year, we're not seeing a lot of disease come back even after we stop when we apply these stringent criteria. What we really need to see, though, is longer-term follow-up. What happens at 2 years and 3 years and beyond? Because how are we going to be able to tell people to stop if we're just going to restart therapy in a year? But this is definitely very promising. Abstract 3247, the Freedom trial, also addresses a similar question. They're screening patients for 2 years to confirm sustained MRD negativity before stopping maintenance therapy. And so 20 patients have been screened so far, and they're going to be reporting on the use of peripheral blood techniques like mass spectrometry and circulating myeloma cells, as well as the bone marrow microenvironment as part of exploratory analyses. Now, I'm really excited about our abstract, number 870, which is what we call MRD to stop. And we design this in a similar fashion, where we have patients who are undergoing discontinuation of maintenance therapy who have had at least a year of maintenance. They have had either a deep complete response, in other words, they're MRD negative already, or they've had a sustained complete response for a long time. So these are patients who on average have had 3.5 years of maintenance therapy of some kind, although they were only required to have at least 1 year to be on the study. So far, we have 38 patients who we're reporting on, and all of these patients were MRD negative using clonoSEQ at 10 to the minus sixth, which is one of the deepest assays that we have, or the deepest assay. negative by a PET scan, and by our own local flow cytometry, which is a little less sensitive. And then we're following patients yearly with bone marrow biopsies and PET scans, and every 3 months with blood testing. One of the cool things that we're doing in this study is really trying to figure out if there is an even more sensitive bone marrow assay, which we'll call 10 to the minus 7th, meaning picking up one myeloma cell out of 10 million. So at the baseline, when we screened patients, obviously we didn't discontinue therapy in anybody who had detectable disease. So all 38 patients were by definition without detectable disease using our standard clonoSEQ 10 to the minus 6th approach. But 4 out of those 38, 11%, did have detectable disease using this novel assay at 10 to the minus 7th. And these 4 patients all had MRD resurgence, meaning the MRD levels reached above the threshold for the standard clonoSEQ assay after 12 months, 2 of whom had disease progress shortly thereafter. So another way to say this is that using the standard clonoSEQ 10 to the minus 6th approach, 21 out of 25, or 84%, had sustained MRD negativity at 12 months, and 96% had no progression. But using the modified 10 to the minus 7th approach, 20 out of 21, or 95%, had sustained MRD negativity at 12 months, and none of those patients have had any progression. So, all of these studies have limited follow-up, and we really need longer-term follow-up to understand the right time to intervene and to identify which patients really should and should not undergo discontinuation of maintenance therapy. The RADAR study is undergoing in the UK that's going to be helping to answer this question. And the SWOG S1803 study is a really important study ongoing in the United States, looking to try to answer some of these questions about duration of maintenance therapy using MRD.